malocclusion, its etiological consideration and the treatment approach. Okay, this is the subject which is necessary to understand the malocclusion development. Okay, so let me quickly introduce myself. I belong to this school, Kanagawa Dental University. This school located in near Tokyo. Here is Japan, and this is a Tokyo area. Yeah. So here Tokyo, my place is just south of Tokyo. It's about 45 to 50 minutes from Tokyo, very close. And so I was graduated from this school, Kanagawa Dental University, 1971. Then 2010, I was academic dean of this school, but now I retired, but only research part I'm doing still now. Okay, so I'm a member of the Edward Angle Society, North Atlantic component, United States, and I was the visiting professor of Vienna, the Krems University in Austria. Then I started my Vienna orthodontic course. This is actually 3 years course from 1998. And also, I'm doing the course in United States, the IDEA course. This is a 6 days course. Still, I'm doing this kind of course. So, let me talk of my research subject, the developmental mechanisms of malocclusions and its treatment approach. This is my, my research subject, but also the diagnosis of function and the dysfunction of the masticatory organ and interdisciplinary approach. And number 3, physiological function of bruxism in the psychosomatic system. And number 4, relationship between the brain and the masticatory organ. Currently, I'm concentrating this subject to the research. So, okay, in my life, I met 2 important teachers. Yeah, this is Dr. Yang Kim. I met him 1985. Then I learned this interesting tool, wire, the multi-loop edgewise arch wire. In my practice, nearly 100%, I'm using this interesting wire. I will show you. And one more guy I met, the Professor Rudolf Slavček from Vienna. Yeah, I met him 1989. Then we are working together and still, research together. Yeah. Okay. So purpose of this course, I try to give you the idea about understanding the development of malocclusions and treatment planning based on solid diagnosis and the treatment of malocclusions, avoiding surgery and premolar extraction. So, okay, and predictable result that cannot be treated with conventional orthodontics. So, okay. And today, anyway, the subject is open bite problem, open bite and class 3. But I will show you this open bite and class 3, the kind of family, etiologically and treatment approach almost the same. Therefore, I like to start the talk about the open bite first. Basically, in a population-wise, open bite prevalence of open bite is something like 10% in population. Yeah, that means many open bite malocclusion. But not only Japan, but when I visit the United States or Europe, I ask to the many orthodontic professors the open bite malocclusion. How do you treat open bite problem? Many professors said, well, it should be surgical orthodontic treatment. Many professors say like this, but to me, open bite, class 3, I never do surgery or premolar extraction. Or, this is, to me, anyway, open bite malocclusion is a rather easy malocclusion to treat orthodontically. So, therefore, usually open bite malocclusion, the people have this kind of question. Why open bite? Is it difficult to treat open bite? Many people say, well, relapses. After orthodontics and orthognathic surgery, many treated case showed relapse. But it's something wrong, something we are misunderstanding. Therefore, I like to talk this also. And relation of class 3 and open bite, this is also important subject to think about. Well, finally, I like to show you the guideline for open bite treatment. Okay, so here I showed many open bite cases. Yeah. Anyway, anteriorly bite is opening. Why? Why anterior open bite? So this is a first question. Yeah. If you understand this why open bite, open bite treatment is rather easy. Okay. So let me show you the previously orthodontically treated cases. Okay, for example, here the premolar extracted cases. Once again, all these cases previously orthodontically treated with 4 bicuspid extraction. But 1 year later, 2 years later, again, the anterior bite is open like this. So that means premolar extraction doesn't work to treat open bite case. Yeah. Therefore, yes, about 35 years ago, I gave up to extract premolars. So, but even non-extraction cases here also previously orthodontically treated, but again anterior bite is opening. So why anterior bite is open? This is a basic question. So okay. So we have in Homo sapiens we have wide variation of faces. Yeah, like this very extreme case, class 3 face, and another extreme case, class 3 skeletal class 2 case. But actually, we have in between, we have many different types of faces. Why such a wide variation? So, yeah, because we have to understand something etiological factor to open anterior bite. Therefore, we should do like this. The developmental characterization of skeletal class 3 and open bite, of course, class 2 also. This is the basic approach to understand the malocclusions. So, if you think about something evolutionary background, so 4-5 million years ago, our body posture like this, the 4-pedal being, and our face was looking down. So this was our original posture of the body, but slowly, or not slowly, this is rather quickly, we our body posture changed, more uprighting, standing, and now 2-pedal being. Yeah? And at the same time, our craniofacial morphology also changed. It's uprighting. After uprighting, our facial growth in ontogenetic stage, the more and more verticalize the face. Now we have a very flat face, and upper and lower jaw is anteroposteriorly compressed. Yeah? This type of the facial morphology. So you can see here the newborn baby. Their cranium is very big, but lower face here is a very small, immature type of the lower face. But after birth, the lower face is growing very much. Yeah? almost vertically grows, not anteroposterior. Of course, some anteroposterior growth, but mainly the vertical growth. So you can see here the newborn baby, the 5 years old skull here, slowly increasing lower facial height, and in adult, the more increase the lower face. This is I want to say our facial growth is not so much anteroposteriorly, mainly vertically growth, increase the height of lower face. So, well, this is our the newborn situation. Okay, this human craniofacial complex, the neurocranium at that time already completed something like 60%, but visceral cranium, facial part is maybe only 30% the completed, but the rest of 70% we have to grow after birth, right? Therefore, this is the starting point of human craniofacial complex growth. At that time, skeletally class 2, because mandible is very small relative to the upper jaw. So then poor vertical dimension, because at that time occlusal plane here, this, of course, if milk teeth are erupting, we will have occlusal plane here. This occlusal plane goes through the condyle. Therefore, the vertical dimension is almost 0. Yeah, and this occlusal plane is a very steep, steep inclination, and no DPO. The DPO is distance between occlusal plane and the condyle here. Yeah. So this is also almost 0. So anyway, the facial growth starting like this. Then finally, maybe age 13, 14 years old, the permanent dentition will be completed. Then variation is something like this. Class 1, the 45%, class 2, another 45%, then class 3, the 10%. Yeah, this kind of variation. So how this skeletal morphology will develop? So this is well, the newborn baby through permanent dentition stage. You can see the change. The slowly milk teeth erupting, then occlusal plane a little bit posteriorly down. Therefore, DPO is increased slowly. Then milk dentition completed. Yeah. Then 6 years molar permanent molar erupting here, the more occlusal plane posteriorly down, then DPO is increased. Then finally, all the permanent teeth are erupting, then occlusal plane is pretty flat. Okay, this kind of growth of our face. So in my department, we have the growth sample. This is one of the sample which is normal growth. That means a class 1 growth longitudinal sample. So this is every year the cephalogram we took, then superimpose. Maybe you can see easily this occlusal plane, even this is a normal growth sample. The posterior part of occlusal plane is slowly, going down. They are going to be more and more flat occlusal plane, because if you compare the anterior part and the posterior part, if you observe the particle dimension increasing amount, this is clear. The molar area particle dimension is more increased than anterior part. Therefore, occlusal plane slowly the flattening. Well, if molar is more erupting, then increase vertical dimension, the mandible very, dangerous situation, because easily opening. But if you see this mandibular plane here, its mandibular plane angle is also decreasing. That means mandibular plane is closing, not opening, always closing. That means the mandible, if increase vertical dimension, the mandible is rotate forward. That's why the mandibular plane angle is decreasing. This is normal growth. Okay. So we have data from England. The Bhatia and Layton published a long time ago this kind of measurement research. Okay, from 4 years old up to 20 years old, every year change the occlusal plane, yeah, then slowly flattening, posteriorly down, yeah. Then same time, mandibular plane angle here is also slowly decreasing, yeah. So that's why if vertical dimension of molar area increase, then mandible is rotate the forward. At the same time, if we measure the ABOP, AB means the maxilla and the mandible, the anterior limit here connected line, and the occlusal plane, this angle, no change. Even occlusal plane changing, but the ABOP is always something like a 90 degree. Yeah. So, because mandible is anteriorly rotated, but at the same time, slowly coming forward. Therefore, something like this, the occlusal plane change, mandible rotate forward, yeah. Then same time, sorry, same time, mandible come forward position. Therefore, always ABOP maintained 90 degree. So this is a kind of principle of facial growth. The vertical dimension change and the mandibular adaptation by rotation. And finally, many people establish class 1 upper and lower jaw relation. So good. This is an adaptation of the mandible. Good. So that's why human face showed such a wide variation is the human facial growth is something like this. We are started class 2 skeletal, then sometime or someday they are establishing the class 1 skeletal. I think this is maybe age 5, 6, 7 years old, but about half of population growing kids establish class 1, but another nearly half of the growing kids stay class 2 because not enough increasing vertical dimension in posterior part of dentition. Yeah, and from here, about 10% jump to class 3 because the more occlusal plane flattening, that means increasing vertical dimension here. So, and this is class 3, but this is adaptation processes. Yeah. Therefore, we should understand this way. The class 2 skeletal problem is, many orthodontists talking about, this is a class 2 growth. Yeah, but this is not class 2 growth. Our baby showed originally class 2. Therefore, just they are staying class 2 situation. In other words, they fail to become class 1 for some reason. We have to find out this reason, then treated that part. Class 3 is mandible adapt too much forward. This is still the adaptation because too much increase vertical dimension or too much flattening the occlusal plane. Therefore, mandible must adapt more and more forward position. That's it. So, okay, then let me explain the class 1, the increase vertical dimension and the little flattening the occlusal plane, the mandible adapt by rotation this way. Yeah, this is class 1 skeletal. The class 2, this is one of the example, it's during the growth, not so much increase vertical dimension, posterior part. Therefore, occlusal plane always very steep inclination. Therefore, mandible have no chance to adapt forward position. Then just the opening. Therefore, this is class 2 skeletal established. Class 3, as I explained before, yeah, very much increase the posterior vertical dimension and very much flattening occlusal plane. Therefore, mandible rotate very much forward and at the same time come forward. This is class 3. Okay, today, maybe this webinar seminar course, class 2 subject, I will talk about maybe third times of this seminar. Today, anyway, open bite and class 3. Yeah, because this is a class 3, but too much increase vertical dimension posterior part, therefore the mandible adapt forward, but sometimes too much increase vertical dimension, then little bit opening anterior bite. That's why the many skeletal class 3 case accompanying open bite problems. And why so too much flattening of occlusal plane? I published a couple of the papers. You know, most factor influencing to the occlusal plane ulceration, I think one of the big problem is posterior discrepancy. Yeah. So, okay, this is again, once again, I like to show this is again the once orthodontically treated case, then again open anterior bite, yeah, even premolar extraction, then treated, but the anterior bite is opening. Therefore, well, many traditional orthodontists do this kind of fixed retention upper and lower, and this is no meaning. Always I say stop to use this kind of retention. Yeah, we have many this kind of case. Premolar extraction, then after treatment, once again open bite. Yeah, but okay, this is case. I try to treat this case. Yeah, once again treated, but what I did is the upper and lower third molar extraction. This is big problem. The molar crowding is a big problem. After third molar extraction, then treat again like this. Now this is a pretty stable. This is another case. Again, the premolar extraction and previously treated, but once again open bite like this, because here the problem, the molar crowding. Yeah. So therefore, we have to eliminate molar crowding. This is I want to say the posterior discrepancy. Then treat again. The treatment just simply the change occlusal plane. Yeah, then quickly change occlusal plane, then finish like this. So class 3 also same. This is the same. this 18 years old male patient, the class 3 anterior open bite, very severe. Actually, this is not my case. My city, some orthodontist, long time try to treat, but didn't work. So this is the situation of panoramic X-ray and cephalogram. Yeah. Then if we see the sequence of cephalogram, you can see here, this is 7 years old, 9 years old, up to 18 years old. The class 3 development like this. The problem is, if you see occlusal plane, especially this 11 years old, the tooth number 7 or 8 is growing, and slowly eruption start. Then this occlusal plane more and more flat. Yeah, then finally, this kind of very severe skeletal class 3 open bite development. Yeah. So there are strong tendency to open anterior bite in Homo sapiens sapiens during the growth and development, because the Homo sapiens sapiens, we are uprighting, the posture change, then we have a big problem in posterior part of dentition, not enough to adapt all the molar eruption. Then this influence to the occlusal plane inclination or vertical dimension. So we have to think about this. After premolar extraction orthodontic therapy and the orthognathic surgery, there still exists tendency of anterior bite opening. Yeah. So anyway, we are uprighting, and also a craniofacial complex during the ontogenetic processes, also uprighting. Yeah. So if you compare the primate and Homo sapiens sapiens, so our anteroposterior dimension is very much compressed. Therefore, upper jaw is only the vertically growth. Therefore, always problem is in the posterior part of dentition. We have a big problem of posterior discrepancy. If this posterior part of jaw, upper jaw, not so much growth. Always we have posterior part, not enough space to adapt all the molars. Yeah. If we compare the 5, 6 years old skull here and full eruption of the teeth, this stage, the anterior part of dentition and posterior part of dentition is almost same dimension. That means this growing kids have to grow this tuberosity area this much, growth. Otherwise, we cannot adapt all the all the molars. Yeah, this is the posterior discrepancy problem. So I published this 1994. This is one of the big, very important etiologic factor to develop the many malocclusions. So if we have the posterior discrepancy, sometimes molar over eruption, too much erupt, then anterior bite is opening. Not only this, but also the majorly inclined the buccal segment, the push forward, then inclined forward. And this is also a big problem. So anyway, this is the modern human problem. Evolutionary, we have a problem here. So we have to consider this posterior discrepancy. Yeah. So posterior discrepancy causes many dental problems. Malocclusion, class 3, open bite, crowding, sometimes mandibular lateral displacement, and also the perio problem, and the occlusion-wise, the molar interferences, and therefore the TM joint dysfunction problem and relapse problem. Yeah. So this is a really problem, posterior discrepancy. For example, long time I did course the United States and Europe. Then I saw the many cases. Then I collected the so-called the third molar full eruption cases. Yeah, let me show you a couple of cases. This young boy, a 20 years old boy, see the almost third molar full eruption. The full eruption. This is the problem. During the eruption, the pushing the previously erupted teeth and also buccal segment pushing and the inclined tooth forward, then anteriorly bite opening. Yeah, this is problem. Another case, same. This is I don't know age no, but anyway, this lady also the third molars erupted, but some anterior crowding, anterior open bite, this kind of problem. So another case, 20 years old boy, the full erupted third molars, and but pretty severe crowding and class 3 occlusion. So you can see here, this he brought panoramic X-ray 2001. There are no problem here, but 2004, the milk teeth are slowly gone and start premolar extraction, but the posterior part, the pushing the more forward and the inclined this premolar, molar. That's why the tooth number 4, 5, something like an impaction of tooth number 4. Yeah, this kind of, the problems happen. And another case, this 42 years old the lady, she did left side third molar extraction long time ago, but right side still third molar exists. Therefore, all these buccal segment inclined forward and anteriorly bite opening, and also joint problem started. The joint, flattening and the resorption. This kind of problems. Well, this is also same. Still third molar not fully erupted, but already anterior open bite, this kind of problem. And this is also same. So anyway, in the orthodontic point of view, the occlusal plane is very important. So many animals, if you see, their occlusal plane is pretty stable. Not so much change. Only human growing kids showed always changing vertical dimension, occlusal plane, and mandibular posture. So therefore, today, this open bite class 3 problem, anyway, the problem is vertical dimension posterior part increase and the mandibular plane, mandible anteriorly rotate. This is adaptation. Then mandible, but sometimes it depends on how much increase the vertical dimension. Sometimes if mandible cannot adapt correctly, then little bit mandible is opening. Then create anterior open bite. Very simple. Therefore, in the treatment, simply we can change occlusal plane, then close anterior bite. This is open bite. So, in definition of anterior open bite, the upper and lower incisors fail to overlap vertically. This is open bite. And also the upper and lower occlusal planes fail to overlap at incisor level. So, sorry, I like to skip this. And this is also I showed already. This premolar extraction anyway doesn't work. Therefore, in our treatment, I like to recommend before start orthodontic treatment, if patient has a posterior discrepancy problem, we should eliminate this problem first, then treat. So, okay. This is, let me show you the one data. This is from Dr. Yang Kim. He published this paper 1974, long time ago, nearly 50 years ago. What he did is different malocclusion group, class 1, 2, 1, 2, 2, and class 3. Then which group showed more open bite? Open byte is a red bar here. It's very clear. Class 3 group showed 83% the open byte appearance, right? And but the class 2, we have no open byte. All these group are deep over byte. But the class 1, the 4.5% open byte. Class 1, the 16% open byte. Something like this. We have little different skeletal type of open byte malocclusion. The class 3 and class 1 open byte and the class 2 open byte. And we have one more open byte. Currently, this is a big problem, but we call this acquired open byte or secondary open byte. This is also class 2 group. We can see the pretty many this secondary open byte. Of course, we have to differentiate the treatment approach. Yeah. So class 1, 2, 3 open byte and the acquired open byte. And this is the open byte. But Dr. Yang Kim, he did a long time ago open byte definition of open byte like this. This is clear open byte. But how about this? Is this an open byte or just the overjet increase? Yeah, a little bit difficult. Therefore, he published this paper. He tried to find out some skeletal factor to indicate anterior open byte. Then he did so many measurements, but finally he discovered the most indicator is this skeletal measurement. The AB2 mandibular plane, this angle is a pretty high correlation coefficient here. But also he found this same measurement, but the AB2MP plus FH2PP, Frankfurt to parietal plane, this angle, this is a little more high correlation here. And therefore, finally, he put the name, this combined measurement, the overbite depth indicator, abbreviation is ODI, that we call the ODI. Yeah, this is the indicator for the anterior open bite. So ODI average, the Caucasian average is something like 74.5. Yeah. Then decreasing value means open bite tendency, and the increasing value indicating deep bite tendency. This is a very simple indicator he used. Yeah. So if you think about decreased ODI, how decrease ODI? ODI is the almost this ABMP, this angle is ODI, not exactly ODI, sorry, ODI is ABMP plus Frankfurt parietal plane angle. Yeah, but the very important measurement is ABMP. Therefore, sorry, ABMP is here. Yeah, if the vertical dimension of molar area increase, then mandible adapt by rotation, then come little forward position. It makes a decreasing AVMP, or sometimes too much increase vertical dimension, then mandible is a little bit opening. This is also decreasing ABMP, this angle. That's why ODI is a nice indicator for anterior open bite. But another type, especially class 2 case, class 2 open bite case, they showed not enough molar area vertical dimension. Yeah. Therefore, very steep posterior part of occlusal plane. This kind of case, also mandible is opening, then decrease the ABMP angle. Yeah. So anyway, we have this kind of different types of open bite. Okay. So once again, the posterior occlusal plane is, the big problem, but let me show you one interesting case. Yeah, this is a 16 years old boy with an anterior open bite. He came, and well, I like to treat this anterior bite because I can't chew correctly. But he asked me, I want to treat this bite situation, but he was at that time 16 years old boy, very busy to do study to entrance the university. Therefore, he asked me, well, can I wait 2-3 years to start the treatment? Okay, yes, I think so. We can wait. But I simply recommend, if I see this panoramic X-ray, you have a problem in the posterior part here. And therefore, okay, we should remove this third molars. Then we can wait. Then he agreed, and then we remove. Then 2 years after, remove 4 third molars. Then he came with this kind of occlusion. Yeah, the anterior open bite is naturally closed down like this. Not, of course, not a perfect occlusion, but anyway, anterior bite is closing. So, oh, good. Yeah, this is before third molar extraction. After 2 years after third molar extraction, the mandible is closing. Then started orthodontic treatment, but this orthodontic treatment is very easy and not so long time because we remove the etiological factor, yeah, and therefore very easily close, and so then finish like this. Good. Okay. Then this is, I think, 16 years after third molar extraction. Still no opening anterior bite. Yeah. Yeah. This is a sequence before third molar extraction, 2 years after third molar extraction. This is 16 years after extraction. No change of skeletal, That's why I want to say open bite treatment is very easy malocclusion to treat. Yeah, if you decide to eliminate posterior discrepancy, then almost the 50–60% of treatment finish. Yeah, because naturally the anterior bite is closed. The task of orthodontist is just a little bit get more nice biting situation. That's it. Therefore, easy. So let me show you the different types of open bite. Class 1 open bite, the class 1 open bite like this. Yeah? Skeletally, not so big problem, and the anterior open bite, but class 1 molar relation, just a little bit crowding, and skeletally anyway, class 1. So the third molar extraction necessary, yeah, it's clear, and the mechanics. As I said before, I'm using this kind of wire, multi-loop edgewise arch wire. Then I put, we call this tip back bend, something like, the curve here. Like a rocking chair, the type of curve. Yeah? Then use one elastic here. The first loop to first loop, we call this a vertical elastic. Then try to little bit upright and little depress here, molar area. Then close anterior bite. I don't like to extrude anterior teeth. This is not stable. Therefore, just keep anterior teeth, no extrusion, no intrusion. Then molar, control molar and occlusal plane. So like this, put the bracket, then 1–2 months leveling, then put multi-loop with tip back bend. Maybe you can see this lower buccal segment inclined too much forward. Therefore, slowly uprighting. Yeah. This in this stage, the upper arch is a little narrow. Therefore, I applied. This is a Mulligan overlay wire for arch enlargement. Yeah. Then uprighting okay, and the occlusal plane okay. Then you can see molar is now opening, no contact. Yeah, this is okay. Then finish. you can see here also the separate the molar occlusion. After finish, naturally this 6 and 7 come down and establish occlusion. After treatment, like this, maybe you can see this panoramic. The 6, 7 area is a little bit opening. So, okay, this is the before and after superimposition. How about the class 3 open bite? Even class 3 open bite, this is not so big problem. Rather, rather easy treatment. So, this is 18 years old lady, class 3 anterior open bite. Yeah, upper and lower, and see the molar crowding or posterior discrepancy. Therefore, we have to remove all these third molars and correct this upper and lower occlusal plane. The mechanics is almost the same, but tip back bend, the little more strong tip back bend on upper jaw than class 1. Yeah. Then almost the same, the first loop to first loop, vertical elastic. Then try to make, class 3 case, too much flattening occlusal plane. Therefore, I want to make a little more steep posterior part of occlusal plane. Therefore, upper multi-loop, I like to put little stronger tip back bend than class 1. So then here, started multi-loop, and if necessary, the upper second loop to lower first loop. This is, I want to say, short class 3 elastic. And the upper jaw enlargement, I applied this Mardigan overlay wire. Then see, if you success the change occlusal plane, the mandible adapt little bit backward position. Then finish like this. Then follow up. Okay. Yeah, this is, I think, 2 years after finish orthodontic treatment. Now, class 2 open bite. Class 2 open bite is really difficult. Yeah. This is, I think, always class 2 treatment is the more difficult than any other malocclusions. This 27 years old lady, class 2, the anterior, actually this is open bite, little crowded, therefore some contact here, but this is molar looks class 1, but skeletally class 2 open bite. All these buccal segment, see the inclined too much forward, we must upright all these buccal segment, up and lower, yeah. And the ODI, I don't know, ODI 79, maybe this is a little mistake. I think more small, this angle. Yeah, okay. Anyway, class 2 open byte. Then this case, sometime I select the lower third molar, always lower is third molar extraction, but the upper, in this case, this is condition of the 7 were not good, therefore 7 extraction, then we decided that this 8 should use instead of 7. The mechanics now little different from class 3, okay? We have to make the flat occlusal plane in class 2 open byte. That's why after uprighting, I want to extrude the 6 and the 7. Yeah? Then lower premolar should extrude and upright, and the molar, lower molar should little bit intrusion. Then finally, I want to make a flat occlusal plane. Yeah, so that I put you know, the extrusion bend in 6 and 7. The lower premolar are between canine and the first premolar. I put extrusion bend, step up bend, then pretty strong tip back bend like this. Okay. The mechanics basically is something like this. Okay, then treatment start like this. Sorry, this is the first 2-3 months. I use this, we call this modified offset arch wire, not a multi-loop, in order to only 6 uprighting, or lower 6 and 7 and 6 uprighting. I use the open coil spring here. After that multi-loop, then continue to upright all this buccal segment. Yeah. Then finish like this. Okay. Good. This is after treatment, and good. Before and after, maybe you can see the uprighting buccal, all this buccal segment, and before and after superimpose. Here mandible is little bit close and a little forward repositioning. Yeah. Yeah, this is nearly 1.5 years after treatment. The bite is reasonably maintained. No bite opening. Yeah. Now tooth number 8 is erupted in tooth number 7 position, and now acquired open bite or secondary open bite. This is caused by the degenerative joint disease, osteoarthrosis. Maybe this this subject I will talk, so the 4-5 modules of this course, more detail, but quickly one case I will show you. The 18 years old, the class 2 open bite, and she had a little TMD problem. The anteriorly, the bite opening, see, then you can see many, this canine premolar area, we can see the many facets. That means that she had the biting upon the lower teeth before, but slowly opening, and therefore secondary open bite. So then already condyle is resorption, the small condyle here. Of course, third molar extraction necessary, and mechanics is almost the same as class 2 treatment. Yeah, molar extrusion, premolar extrusion, uprighting, lower molar intrusion, yeah, something like this. Okay. Then start treatment, then leveling, multi-loop, then start changing occlusal plane, anterior bite is slowly closing, then, okay, almost good, finish, then, yeah, this is some, yeah, this is a follow-up, but no tendency to the bite opening again. So superimposition, also you can see by mandible is a little close and adapt a little bit forward position. This is 10 months later, bite is okay. And this is 4.5 years after treatment, still bite is okay. And no open anterior bite. And this is before, right after orthodontics, and 4.5 years after treatment. Then I compare the her condyle previously before treatment, the flattening here and here, yeah. But 4.5 years after, now condyle is very round shape, and morphology is changing. I think remodeling is going on. Good. So this part of conclusion is okay. Open bite treatment is not difficult. In diagnosis, it is strongly recommended that the posterior discrepancy and the occlusal plane must be considered. In the treatment, it is necessary to control occlusal plane, especially those of posterior occlusal plane. And molar uprighting is important, not only molar, premolar also important to stabilize the occlusion. Good. Now, let me talk about the class 3. Maybe I hope you understand class open bite. Therefore, now class 3 is easy to understand. Okay, this is class 1 growing subject. But the class 3 case, you can see so many molar eruption, the very flat flattening the occlusal plane. Then mandible rotates very much forward. Therefore, mandible coming too much forward, adapting. This is class 3. Now, let me show you one case. She is 17 years old. She did the orthodontically treated 4-5 years ago, yeah, with only lower first premolar extraction. Once again, this is I can't understand why only lower premolar extraction. But she said, once my bite is the corrected, then no this kind of lateral open bite. But after I finished treatment, then 1 year, 2 years after, slowly this part lateral bite is opening. Then she complained to her orthodontist. Well, I can't chew here, but her orthodontist say, no, you have maybe a genetic problem. Therefore, it's impossible to orthodontically treat again. You need surgery. But she didn't agree this idea. Then she came. So, well, I don't like to remove too much tooth substance, but sorry, I have to remove the third molars to eliminate posterior discrepancy. Then anyway, I did treatment, just uprighting here and change little occlusal plane, then finish like this. Yeah. This is after treatment. So if you compare the profile, also a little bit improve. Yeah. Because this kind of occlusal plane control provide little mandible adapt backward position. Therefore, profile change. So something like, okay, this is the case which some medical school plastic surgery department doctor sent me this case. He had the hemifacial microsomia. This kind of problem. His ear, one side of the ear missing, and here no joint, no condyle. Yeah, maybe you can see here frontal safe showed the left side condyle here, but this side no condyle. So panoramic also showed that here we have a condyle and the joint, but the right side no joint, no condyle. So this kind of the problem, if we are missing right side of the condyle, maybe occlusion will be crazy. But if you see his occlusion, the right side his occlusion is more class 3 occlusion. Yeah, anyway, both sides class 3, but right side more class 3. And anteriorly little bit open, right? So this is indicating something, you know, the class 3 development in Japan, the long time ago, many orthodontists talking and discussing class 3 is something genetic problem. Therefore, we cannot treat orthodontically. This kind of discussion, but you know, even no condyle, but class 3 occlusion develop. So therefore, I think anyway, this is important vertical dimension and the occlusal plane. So this case, I treated same way, just simply this all these upright and establish close anterior open and establish this occlusion. Originally, this case was right side condyle and joint reconstruction surgery. This was planned, but well, I treated like this, then sent him back to the medical doctor. Then he said, "Oh, you have now nice bite here. Oh, this case, then functionally no problem. Then, oh, not necessary the surgery. Yeah, then stop to the surgery. This kind of story. So, okay, now if you see this common symptom, the class 3 people, yeah, this is a little crazy, but you know, skeletal class 3 people, the lower dentition, the usual curve of sphere, we cannot see in skeletal class 3 case. Always the reversed curve of sphere. Too much eruption in the molar area. Therefore, always skeletal class 3 and anterior open bite. Yeah, this is a common symptom. Yeah. See, here, very flat occlusal plane and too much vertical dimension here and high angle. That's why sometimes this kind of case, orthodontists call long face syndrome. Yeah. So this is also the same type of case. He's 20 years old, the high angle class 3, then anterior open bite, here, reversed curve of sphere, then contact only upper 5, 6, 7, lower 6, yeah, this part of contact, then anterior open bite. So, same, long face syndrome, very flat occlusal plane, yeah, posterior discrepancy. So this case, anyway, like open bite treatment, same way, eliminate posterior discrepancy, then, yeah, that's why third molar extraction, then try to treat, change occlusal plane, that's it. But yeah, this case, this patient, a very bad patient, he didn't come half a year, with multi-loop and yeah. So then his oral hygiene is very bad. Then I gave up to continue to treat, then finish like this. And therefore here, some, decalcification. But anyway, this kind of case, anyways, showing something possibility to change or correct the class 3 open byte case. This is before. This is not after, but anyway, some improvement. So in my department, we did this kind of treatment, many. Then, class 3 treatment and the open byte treatment, almost the same approach, because posterior discrepancy. So this young boy, the 13 years old boy, this is an interesting case. At that time, 13 years old, class 3, anterior cross byte, but not open byte. But a half year later, slowly anterior byte is opening. Then 1 year later here, already here the milk teeth are gone, and anterior byte is opening. Then 2 years later, 2 years after from here, now 15 years old, something like a reversed curve of speed, anterior open byte. Anyway, only this 2 years, changing like this, more severe class 3. So if you see the sequence of this 2 years, the panoramic observation here, then buccal segment or premolar exchanging start, then the 7 eruption start, then 6 years molar, something squeezing out. This is, I think, a pathological eruption. Then finally, the reversed curve of speed here. Then also upper molar, also too much eruption. I measure, so, okay, the cephalometrically observation before, the half year later, little bit anterior byte opening, then here, the 2 years later, very much anterior byte opening. Then this is a superimposition of cephalogram. You can see the too much eruption of 6 years molar. I think this is a pathological situation. Pushing the first molar, then too much over eruption. Then mandible is a little bit opening. That's why the more severe class 3 and the anterior open byte. Yeah, clear. And some case, this is also interesting case. This is not my case. My friend, the friend's office, she came. So anyway, she had anterior open byte like this, but she visited some dentist. Well, I cannot bite. I can't chew. I want to correct this. Then the dentist say, "Oh, you have an anterior open byte. maybe too much eruption of the molar area. Therefore, okay, you should eliminate this dental height. Then grinding here. Then, she did 2 years, this kind of not a treatment. If grinding the 6 and the 7, then little bit anterior bite close, then now I'm happy. But 3-4 months later, again opening, then go to dentist, then grinding again, then little close. This kind of crazy treatment she did. Finally, pulpectomy or all these done, but still anterior bite is opening like this. Maybe everybody, think about this kind. This is crazy approach. So, simply you can see here the posterior discrepancy here. Just simply the remove third molar. That's it, I think. But I'm very sad this kind of case. Okay, now the class 3 almost class 3 is etiological factor is almost the same as open bite development, right? Therefore, treatment mechanics. Okay, this is 19 years old, the male patient, but well, actually he came to my department at 7 years old, but a long time ago. Then not a success, the treatment. Then she come again, but she didn't like to do surgery. But okay, occlusion like this. This is 1989. At that time, I saw him. Then, okay, maybe without surgery, then possible to treat. Then we start the treatment. Okay, this is cephalogram at 7 years old and 19 years old. If this is also, the posterior discrepancy, the superimpose here, so much change this occlusal plane, posterior part down, then very much flat, the occlusal plane. Mechanics, again, same. Basically, the tip back bend, the little stronger tip back bend on the upper, and also lower, of course, tip back bend, and elastic use like this. Of course, third molar extraction necessary. Then start treatment. So maybe you can see this posterior occlusion. Once we should separate. Then mandible adapt a little backward and finish like this. Before and after. This is superimposition. Maybe you can see this mandible, the reposition backward, maybe 3 millimeter, 3-4 millimeter mandible adapt the backward position. Good. This is also very severe high angle class 3 case. Yeah, this is her bite. Well, this is also 10 years ago. She did orthodontic treatment with only lower first premolar extraction. But slowly again, anterior bite is opening. Once again, I like to emphasize the premolar extraction doesn't work. Yeah. The etiology is more posterior part. So here, of course, this case so severe high angle class 3 open bite, therefore I simply recommended you should do some surgical treatment. But she didn't agree. No, I don't like to do surgery. Then we discussed maybe 2 months, 3 months, discuss. Then anyway, she wanted to correct as much as possible because she cannot chew. Yeah. Okay. Finally, I try to treat. Okay, third molar extraction and leveling start. This, approach mechanics is same. Yeah. This way. Then uprighting necessary. Yeah. So, well, this case, I think 18 months I approach to treat. And finally, this is a compromised treatment, but she needs some prosthodontic reconstruction posterior part. Therefore, I finish like this. Okay. But the skeletally, not so much change. This is 1 year later. Little bit relapse here, little opening. This is 2 years after. Little more open here and here. But the original plan was reconstruction of posterior part, prosthodontically reconstruct. But she said, no, I'm okay, I'm fine. And therefore, I want to keep like this. Yeah, this is the story. Another case, well, this boy, sorry, this photo is not good, but anyway, at 11 years old, he had no problem in the profile, little occlusion, little problem. Then he corrected, but then orthodontic treatment finished. But now he's 22 years old. Then he came with this kind of skeletal, the big problem. Class 3, and the bite is class 3, of course. And so, also one of the very important findings, well, this kind of severe class 3, but 12, 13, 14 years old, not so severe. But the high school age, then mandible adapt more forward, because at that time, the 7th eruption finish and the third molar growing and the eruption still going. Therefore, occlusal plane continuously flattening, then it makes this kind of the problem, very flattening upper occlusal plane. So, but anyway, the treatment is same. Oops, sorry. The third molar extraction, then treatment, again, same mechanics, leveling, multi-loop, uprighting, change occlusal plane. This is a little enlargement of upper arch. So, then finish like this. Okay. And yeah, the profile change nicely. And I think if I compare, sorry, this is right after finish orthodontic treatment. You can see little opening posterior part. Yeah, but this is 1 year after. Slowly, naturally, the molar getting contact and occlusion, it's good. This is the before and after superimpose. The profile change like this. And follow up. This is 2 years after. Yeah, not so much change. Good. So it's almost time. Therefore, okay. Quickly, I like to show you couple more case, class 3 treatment. This is a 13 years class 3, the female patient before treatment, then after treatment, like this. Yeah. Okay, another before and after the profile change. This is another case, 15 years old patient, and treatment like this, before and after. And then 2 years follow-up. Yeah, keep maintain nicely, and before and after profile change. And this is 17 years female, 17 years old, the female patient, class 3 open bite, before and after treatment, then 2 years after. Okay, maybe that's it. Before and after profile change. Okay, so today I talked about open bite and class 3 malocclusion, something the etiological aspect and treatment approach. Okay, thank you very much for your kind attention. Okay. Hello. Okay, I finished. So maybe question here. So, okay, I got the question. The first question, how many grade of tip back bend do you give to each tooth? Okay, this is, sorry, this kind of seminar that I cannot show. Well, of course, it depends on case, yeah, how much inclined the tooth, and but usually first step, the tip back bend is not so strong. Then next appointment, if necessary, I like to accentuate the tip back bend more. And therefore, this is really depend. So maybe you can control this way. The first step, very the not a strong tip back bend, but slowly increasing. Well, what ball gauge do you use? I don't know. I can't understand this question, but maybe hmm? The size of the multi-loop wire. Yeah, maybe the size of wire in my practice. My edgewise bracket is 18 slot. Therefore, wire I use is 16 by 22. Yeah. What about the tongue and a typical swallow not help the bite to open, increasing long time? This is too old to tongue behavior. If the anterior bite is open, the 100% of such patient have some tongue thrusting habit. This is necessary because the anterior bite is open. But usually, if you correct anterior open bite, naturally tongue problem disappear. Yeah, but maybe very rare case, for example, less than 1% of the case, especially the elderly patient, long time tongue thrusting problem with anterior open bite. Such a case, sometime after closing the bite, still tongue behavior pushing the anterior teeth. Such a case, of course, we have to concern about this problem. Something, the myofunctional training or something necessary. But usually, no. Yeah. With what arch do you design the tip back bend arch? Is straight arch and then place. Leveling phase. I want to use the as a leveling wire. I use Australian wire, the 014 or 016 Australian wire. Just a simple, the plain arch. Yeah, that's it. How many degree of occlusal plane change is possible with multi-loop technique? This is maybe 10 degree to 15 degree. Yeah, it's possible. And the multiple patch also uncrosses the posterior bite if there is one. Uncross, that means the correct cross bite, maybe. Why not? It's, of course, it's possible. Yeah. Okay. So, that's it. Okay. Well, I'd like to finish today's my lecture. So the next, yeah, the 2 weeks later, yeah, the module 2, then see you soon. If you have a question at that time, also I can accept any questions. Okay, so anyway, bye-bye. Thank you very much. Okay, can I finish this?